And so, again, we want to thank everyone for taking time to join in. IRHA is proud to have a relationship with IFN, and one of our primary objectives with that, although we've had many objectives over the years with them, but currently one of our bigger operations is to expand fiber networks and increase accessibility into rural communities. So today we are hosting this session, and we're asking our panelists to share their ideas and talk about the impact of fiber network expansion in rural communities, specifically talking most and focusing on the impact through telehealth, as that's become a major issue for many of our member sites and many people within rural health. So I'd like to start with Cory, if I can. And before we get started, I want to ask everyone to please mute your lines if you're not speaking. The mute button is on your screen down the bottom left corner. And if you would just mute that line unless you're speaking, and then in the middle of the bottom of the screen, all the way down to the bottom, hover your mouse, there is a chat button. Please use that if you want to send us questions. So I will go back to Cory then and say, Cory, why don't you lead us off? Tell us a little bit about some updates, if you would, with what Intelligent Fiber Network has been doing and how that correlates to telehealth and rural health in general.
Thank you, Phil, and really looking forward to this conversation today, both with you, Becky, and Cody, and just discussing, I think, the advancements that we're seeing in telehealth, and I think all the components that need to come together for it to be a successful implementation for rural health providers. If you look at Intelligent Fiber Network, we've had a long-standing partnership with IRHA and the telehealth network going back, I'd say, a decade now, and the expansion of fiber networks into rural Indiana with the connections of the critical access hospitals first, and then through time bringing in behavioral health, skilled nursing, and thanks to the RFPs that IRHA's pulled together for the Healthcare Connect Fund, helping subsidize fiber broadband out to rural areas up to 65%. We have seen our network expand tremendously into rural Indiana, as with other carriers like IFN. That program on its own has connected hundreds of facilities, and part of the conversation today is that component of telehealth and connectivity and its importance as it relates to a effective platform. There's pieces that I'm sure Becky and Cody will fill in the blanks. If you look at IFN's how we help with telehealth, is we're the highway to connect the rural facility to different platforms, and I think there's a funding component, there's a hardware component, and then ours, the piece we care for, is just the access. And I'll speak to just on a platform that was developed by IRHA, and IFN's been fortunate enough to host, and that's just the shared platform. And really the idea, IFN being a means to connect whether it's devices or individuals to each other in a reliable and fast manner. So IFN's owned by 20 independent phone companies, most of them rural. And then most recently we invited another member, Wabash Valley Power and Associates, and that's comprised of several REMCs in Indiana and other states, and that will help to expand fiber into rural Indiana. Think about kind of that last frontier of fiber deployment, and the REMCs will be a great play, or the cooperatives, to extend fiber into the other corners of Indiana where it's still missing. But that's a quick overview of IFN.
Excellent. Thank you, Cory. That's a lot going on, and it sounds like you're doing a lot to bring services into rural areas. I also want to acknowledge Allie Orwig has joined us on the call. She is on the staff of IRHA, and she has had a long relationship with IFN through some programs. Allie, can you just share briefly, I know you know a lot of the members of INCERN and IRHA, but can you just share briefly what your program with IFN has been about?
Yeah, absolutely. Thank you, Phil. I actually run the Indiana Telehealth Network, which is under the IRHA umbrella, and it is the program that provides up to a 65% subsidy for the construction, installation, and then monthly recurring charges associated with high-speed broadband facilities or services into nonprofit healthcare facilities. We've been doing work through this program with the FCC. Gosh, Becky, I think this started back, the very early rumblings began in 2007, and we've been fully functional since 2009. We've worked with upwards of 300 different sites now, helping them obtain funding through the FCC. And IFN has been one of our great partners in this.
Great. Okay, thank you, Allie. I want to shift over to Becky. Becky Sanders on the IRHA staff. She is, if you don't know Becky, Becky is our go-to person for basically everything that's telemedicine. So Becky, if you would tell us about how much telehealth has grown in the area, and if you would share a little bit about how you perceive what the impacts of telehealth and broadband through programs like what we get through IFN. Just give us your overview of that, if you would.
Sure. Thanks, Phil. I'm honored to be joining you guys today. So in my role as program director for the Upper Midwest Telehealth Resource Center, which is kind of like a department or underneath the umbrella of the Rural Health Association, we're federally funded, and IRHA is our fiscal agent. We cover 4 states: Illinois, Indiana, Michigan, and Ohio. And when we started doing this back in 2011, 2012, the questions that we would get when people came to us would be more like, what is telehealth? What kind of applications can I actually do? And do patients really want to see their doctor via telehealth? And those questions have evolved, and they've gotten much more in depth. And the general public that is operating healthcare service lines, be it a CEO or a CFO or a quality director, the programs are getting much more specific. Some of the programs started off, a lot of them start with telepsychiatry, because that's something fairly easy to do with just a HIPAA compliant video conferencing software. You don't need a lot of other peripherals to do vitals, like a digital stethoscope or otoscope, those types of things. And many programs that have moved into primary care, and the newest things that we're hearing about is programs wanting to start dental programs or programs for autism, to do virtual check-ins with children that have a developmental disorder. So that you're seeing telegenetics even. We're seeing just an explosion of interest in telehealth.
So the dental piece is rather new, is that correct, Becky? If so, can you tell us about how that's working to serve in rural communities?
Yeah, and dental is one thing that hasn't really manifested itself in the state of Indiana. As with any new program, you'll see visionaries in the field, and then you'll see other people who are kind of just waiting to see what's going to happen, and other people who are sticking their head in the sand. One of the biggest barriers to dental, and there are some really successful programs in North Carolina and especially in Alaska, but it's the medical licensing board for dentists. So they have to give the dental hygienists, or whoever's going to be with the patient in the rural area, the authority to do that visit, and then have the equipment to bring in a dentist via video conferencing. So the technology is getting easier and easier, but what we're getting caught up on now is the policy, really, because the policy never keeps up with technology.
And is this something where you see Indiana making progress and hopefully catch up, or is this going to be a large challenge?
Large is a relatively strange word. It's a matter of perspective. I think we'll get there. There is some interest from different sectors, but it'll probably be a couple of years.
Okay, great. Good information. Thank you, Becky. We'll come back to you. I want to hear more about, have you share more about the telehealth network that you have. I want to shift over to Cody Mullen. Cody is a PhD on staff of IRHA, and he manages many of our grants that we bring into rural communities. So Cody, if you would share your thoughts on the expansion of grants, if you would, as they relate to telehealth, and maybe kind of dig into the mind of Washington a little bit and tell us where you see from a policy position, where are our federal and state legislators with their approach toward telehealth and as it relates to grants?
Yeah, absolutely. It's a pleasure to be with everyone on this hopefully sunny around the state April day. Spring is finally sprung. So we are seeing a lot of interest from both the Health Resources and Services Administration's Federal Office of Rural Health Policies, Office for the Advancement of Telehealth, to expand access to telehealth programs. That's the division or the office that funds the TRC that Becky is the director of. In addition, the Indiana Rural Health Association has been fortunate enough to receive 2 other programs, one looking at implementing school-based telehealth clinics, another looking at behavioral health and telebehavioral health clinics throughout the state, not necessarily in a school, but in a rural health clinic or within an emergency department. But we're seeing a lot of transition, not only amongst HRSA, but also the National Institute for Health and the Agency for Health Research and Quality, AHRQ, really looking at how do we define the evidence base around telehealth. About 5 years ago, 10 years ago, when you looked at the literature and the scientific knowledge around telehealth, it really hadn't caught up to what everyone in the field knew about what telehealth could do. And we saw a transition December of last year. Health Affairs, the leading journal in health policy, released a whole issue around telehealth, which really was a big step forward for telehealth. But the government, from what we're seeing, is really interested in how do we not only gain access to it, but also build a stronger evidence base to be able to prove without a shadow of a doubt what we're already seeing in the field with the implementation of telehealth. But that is a lot. Excuse me, that creates some difficulty within the rural spaces, as rural spaces don't have as many patients as urban settings do. By building an evidence base does take a greater amount of time. But we're also seeing up on the Hill in Congress and at the White House and the leadership of CMS that telehealth really has become the new frontier. There is a committee looking at telehealth that the TRC under Becky's leadership was able to submit public comment to. I think Congress is really seeing this as an avenue to decrease costs while increasing access, and maybe that golden nugget that we've been searching for the last 30 years to answer the triple aim and the goals of the triple aim. So we're really seeing a lot of transitions. One highlight of that is in July, so 2.5 months from now, for the first time ever, CMS is going to openly fund telehealth being delivered out of the home. It's a very small case, though. It's for behavioral health for substance use disorder for the Medicare population, so 65 and older generally. But it's the first step. And we know that when CMS starts to make steps, Medicaid agencies across the state as well as private insurance agencies across the state take notice and start to make the steps. So I really think in the next 5 to 10 years, if even that long, it won't be uncommon to have an insurance billable service where you're sitting at home doing your annual physical or doing some sort of well check through formal insurance. We're already starting to see that. I know personally last month, something went on and I was able to call the Anthem nurse to say, where should I go? So we're starting to see very rudimentary avenues, but I think we're going to see that really explode, which is exciting for rural landscape, as we're going to be able to see really the hospital being delivered to the home and the setting. And I think the work that IFN is doing, laying that fiber across the state, will make Indiana be the leader in that work.
Excellent. And if you would, Cody, just share with us your personal thoughts, if you could. What do you think that there will be continued interest and maybe more importantly, support from Washington to provide funds for this?
I think it's interesting. I think it's challenging to really see that forethought. with everything that's going on with with health policy right now, I think telehealth is a new frontier that there's a lot of interest on. So I'm very hopeful if that's going to be very formal grants that are very telehealth centric that we're seeing currently. I'm not sure, but I think almost any grant that will be within the rural space will need to have a telehealth flair to it in a way.
Okay.
I think the change is occurring, and telehealth is a part of that change. So I think we're going to see it more as just a status quo than this is a unique telehealth initiative. Let's really focus on it.
Okay, great. Thanks, Cody. I want to go back to Becky, and Cory, feel free to contribute on this as well. But I know one of the big issues in the telehealth world are platforms that we have to use. And Becky, I know you've got a lot of experience with this through different endeavors that you've had, but I'll ask Becky and Cory both. Tell some of our guests, if you would, about the various types of platforms and what you see as the most important things as a facility looks at expanding in telehealth. What should they look at in a platform as what's most important?
Becky, I think I'll let you start with the platform, and then maybe we'll back into how the importance of the connectivity to that platform.
Okay.
Great. Thanks.
So I will say that choosing a telehealth platform or any equipment to be used for healthcare delivery services via telehealth is like choosing a cell phone, to get a really, really simple analogy. There's a ton of vendors out there, and they all offer various plans, services, bells and whistles, but they all really pretty much do the same thing. Of course, there are good vendors and there are bad vendors. One of the things that I have to do with the Telehealth Resource Center is stay very vendor agnostic. So one of the different things that you want to look for to make sure when choosing a platform or equipment is you want to make sure that it's going to augment your existing processes and procedures. You do not want to write a whole new manual on how to do telehealth and totally screw up whatever your scheduling is, whatever your rooming of a patient. Telehealth is not a service in and of itself. It's a delivery mechanism for providers and patients to meet in a virtual space. So whatever makes it more seamless. Some of the electronic medical records do have video components built into them that are already HIPAA compliant. That's something to look into because you don't want to have a separate database where everything's going on and then you have to retype everything or somehow move it over to your electronic health record.
Okay. And Cory, you want to take it from there?
Sure. Yeah, and I think the platform. It sounds like there's several to choose from, and and then what's the user's experience with that? And I think in order to have an excellent experience, the connectivity is going to be the key. And there's lots of just as there are with platforms, there's lots of different means to connect. Broadband is a broad term, and there's lots of different definitions. But at the end of the day, I think fiber is the future, and with your backbones, this connectivity to these platforms, to your users. I won't get overly technical, but bottom line is the speed is important. So bandwidth, and what's the download and what's the upload, and in a fiber environment where you would want to offer your users a dedicated, reliable connection where your downloads and your uploads support the platform that you're offering. And with the technologies today, scale is less and less of a concern. Fiber itself and the glass and light that deliver these signals that allow telehealth to happen are very scalable platforms. It wasn't long ago that 10 meg was good enough. Well, now here at IFN we're seeing that gig is more the standard, and 10 gig and 100 gig, and that's one of the advantages that fiber brings to any industry or any application. But with telehealth and the quality and the experience you'd want to deliver, it would be unfortunate to have a great platform, but to be on an island and not have access to the outside world because of poor connectivity. Mm-hmm. And that's the component that we try to provide is the speed, the low latency, and that real-time experience so that telehealth can be administered.
Okay. Cory, while I've got you on the panel, let me ask, if I'm a provider looking to get into telehealth, before I launch it, how do I know I have adequate bandwidth? And forgive me, I'm somewhat IT illiterate, so if I'm using wrong terms, forgive me. But if I'm in a rural community and I want to start some telehealth or expand the telehealth that I have, how would I find out if I've got adequate bandwidth in my area to be able to launch an effective telehealth program?
Sure, and I hope not to oversimplify this, but the first thing you want to do is, with your existing connection, have a grasp of what your downloads and your uploads are, what kind of speeds you have, and I think anything video these days, much less than 50 meg or 100 meg, may be cause for concern. Of course, there's other demands on that bandwidth beyond telehealth within your organization. So bandwidth is one consideration. And then also, what's the service level agreement? Is that provider guaranteeing, in our world, our guarantees are measured in nines. So, a 5 nines type service, 99.999% uptime is optimal and what you'd want to look for, so that while administering telehealth, you can count on that connection to be available. And then is your connection dedicated? Is that bandwidth that you're receiving always available and always dedicated only to that institution? If it's a shared medium, depending on the time of day, it's possible that one experience with telehealth is excellent, but if you're trying to administer at the same time that everyone gets home from school and it's not dedicated, then that could result in poor performance. So those are just some very simple things. And then your providers, companies that can provide fiber services, maybe the local phone company, maybe the cable company, and then there's players like IFN that are more a regional or statewide type provider, and maybe more of a local type fiber network.
Okay.
Yeah, I wanted to tag on to that. Cody mentioned Cory mentioned schools, especially in our school telehealth program. We've noticed it's very important to segregate the traffic for the health clinic versus the traffic for the rest of the school, especially once you get into like high school. Come lunchtime, all the kids are on their devices, and you don't want that disrupting your telehealth clinic.
Very good.
Becky, you had mentioned EMR and telehealth. Is there a difference in your they synonymous? Are they do you differentiate?
Okay,
but does telehealth help facilitate EMR, or telehealth is just more the administration of medicine?
No, I would say that a good electronic medical record can help your telehealth service to be more effective, because you don't have to do double entry for medical records.
Yeah, and as we know, providers are not likely to want to do double entry.
Right. I was going to share an experience I had with that where connectivity and EMR helped with telehealth. We had an instance where a family member was in a rural hospital, had a procedure done, and those records, looking for basically a second opinion, and those records over some fiber connections were able to be transmitted to one of Indianapolis hospitals kind of instantaneously. The surgeons that were given it a second look had it readily available, and in a matter of hours, second opinions were able to be given and then transmitted back down to the local hospital that we were in. And it was just a kind of a firsthand experience of the power of the connectivity and how it affects, in this case, me as an individual. And it's that no double entry was required in that case.
Okay, good. All right, and I want to have Lee make sure we have time at the end to get everyone's questions in. I've just got a few more, but I want to, so everybody start making notes as far as questions you have. I want to go back to Cody. Cody, what are although we've had a lot of opportunity and some tremendous successes through telehealth and the expansion of fiber networks and so forth, what do you see as the biggest challenges that we still face?
I think the biggest challenges we still face with telehealth are not different than the biggest challenges we face in healthcare in general. We're still having a provider shortage. Providers who don't want to work maybe in a rural setting, who don't want to commute or live in that setting. There are some providers who would prefer not to have a telehealth practice or have a practice in a traditional brick and mortar setting and don't know how to incorporate telehealth in addition to that practice. So I think that's a barrier. I think there's a lot of, while it's gotten a lot better and a lot of work done by the TRCs nationwide, there's still a lot of confusion around the billing and the reimbursement of telehealth. What setting can you bill in? What modifier do you add? That's gotten a lot simpler, but it's still not easy, so it's an unknown. So a lot of people, it may not be the easiest to incorporate that unknown. And then, as Becky mentioned, there's so many different technologies out there. I love the cell phone analogy. I'm going to steal that now, Becky. But, and a cell phone's relatively cheap if I don't like it. What's the worst case? It's $1,000 and I have to buy a new phone, or I wait 2 years to get my next phone for free, or whatever the upgrade plans are nowadays. In telehealth, though, this could be a multi-$1,000 investment across your whole health system. So you need to make sure you get it right, but technology is advancing so fast that if you buy into a system, in 5 years, you may need to be looking for that next system. So I think those are some barriers. I think a lot of people have overcome them. I think they're a lot less than what they used to be. But that's what we're hearing, at least with the grant program that I manage right now, that way. Okay.
Thank you, Cody. Cory, I'm going to go to you and then follow up with Becky on the same question. From your perspective, Cory, with IFN as it relates to telehealth, what are the biggest challenges that you see?
I think there's still a large portion of the state that is underserved as it relates to broadband options, and it's just the expansion and deployment of fiber networks, which is not an inexpensive endeavor. And so I think there's a lot of things being done at the state level, and then with other entities such as your rural electrics that are starting to get into fiber deployment, and the expansion of fiber networks with the telephone companies. And it's those hard to reach areas that have remained underserved for years and years, and it's pushing the networks beyond that point to where we expand into those areas. And I think we're seeing the funding at the state level, the interest in other parties to pick up where others have left off. And then, of course, this Healthcare Connect Fund through the federal level will continue to help expand fiber networks and subsidize those models where in a typical scenario it wouldn't make sense. But with these parties that are coming together, I think you'll see fiber expand a lot more rapidly than what you have in the past, and that will help facilitate these type applications.
Okay, great. Thank you very much. So I want to swing back to you, Becky Sanders, and ask you first of all what you see as some of the greatest challenges from your perspective. And unless I'm wrong, I'm going to say availability of providers is one of those highest concerns and challenges. But tell us what else is out there, and then let's talk a little bit about access to finding providers.
Sure. I'm going to preempt answering your question by asking Cory another question. Cory, what do you think, and it's been a while since I've looked at the data, the broadband access percentage is in Indiana right now, as far as coverage around the state?
Yeah, there's an answer to that. And I might need to Google it. So why don't you give me a minute? I know I'll have to look it up. I want to give you the right percentage because it's been studied, and there is a number out there.
Okay. My guess is going to be like 85%, but we'll see what you come up. Okay, so back to your question, Phil, about barriers to starting telehealth programs. Absolutely, I would agree about providers practicing in rural areas. But the cool thing about telemedicine is that a provider can be anywhere. I mean, they have to be licensed and credentialed in the state where the patient is. They have to be credentialed with whatever healthcare entity the patient is working with or is being seen at. But really, I'm going to say policy. You know, I was talking to a guy yesterday from Chicago who has recently started a national organization for physician assistants. And there are tons of physician assistants out there that want to work in telemedicine, but because of the supervision rules, and here we go back to policy, they can't do it without supervision from a physician. Now, when you're working in telemedicine, no physician wants to supervise somebody that they just see virtually. They just don't want to do it. So there's a surplus of providers that want to work, but no work for them.
Okay, great. Thank you very much. I have a question from one of our attendees. What specialties do you believe lend themselves to telehealth better than others? For example, cardiology, pulmonology, GI, ENT, general surgery, urology, etc. So, Becky, from your experience,
so behavioral health is number one. And then you hear a lot of programs about stroke, telestroke, or teleneuro, because those are time is money as far as heart muscle or brain muscle. And then we get pulmonology and endocrinology, the follow-up, because the follow-up needed with patients, any patient that has a chronic care condition, the follow-up, go every 3 months to your doctor and all that, and it takes a lot of time out of a person's day, especially if they're still working full-time. It's a pain in the butt. So to be able to do that remotely over a secure video conferencing network is a huge boon to the patient, and it helps the provider to have to maximize the way that they see patients in the office.
Okay. Now, Becky, I want to stay with you on this. As we talk about some of the challenges with telehealth, which we know those are out there, let's talk about the limitations of telehealth so that everyone is aware of that. And I think some of the basic limitations being the degree and the extent of the exam, how much of that can be done through telehealth. Can you talk a little bit about that and where that comes into play? How much can we do knowing that we're going to hit a certain point where the physical exam becomes too much of a problem to where we can't do telehealth?
Right. So let me take an example of a sinus infection. When the weather changes, it screws with my sinuses. So every spring and every fall, I'm sick. You can hear it in my voice today. If I were to make an appointment with my primary care physician, she's of course going to take my vitals. They're going to do my weight, my blood pressure, all of those normal things. They're going to listen, take a stethoscope, listen to my lungs. She's going to look in my ears, all of this other thing. And a lot of this falls on the provider themselves. What does the provider, and there's policy around some of it, what does the provider need to collect to be able to make a diagnosis? What does the provider need to collect for whatever insurance internal policies, procedures. And what is it? They talk to somebody and they hear their symptoms and they're like, well, I think it's this, but I'm going to take your vitals just to make sure, because I always take your vitals. I've been able to use my insurance to do a telemedicine visit when I had a sinus infection. I couldn't get in to see my primary care provider, and I didn't necessarily want to go to a minute clinic. I felt bad enough that I didn't want to leave the house. So I did that, and that person didn't have any ability to touch my body or ask my blood pressure, those kinds of things based on the symptoms that I had. Made a judgment call, and I got a prescription for antibiotics.
Okay. All right, good. Thank you for that. So someone from the audience asked about primary care utilizing telehealth. So I'll throw this back, Cody or Becky. You've both seen experience in this from some grants we've had. Is primary care going to grow and expand in telehealth?
I think so.
Okay.
I think once we change the law that you don't have to be in another healthcare setting, that will make it a lot easier. So right now, if it's primary care, that's the easiest to do in like a rural setting, or a one doc or one nurse practitioner PA practice. So once you don't have to go to that physical location, I think it'll be a lot more.
Mm-hmm.
Okay. We've heard a lot of discussion about CMS, who governs Medicare and Medicaid policy, and what their extent of allowing telehealth is. What about commercial payers? We still have some of those out there, not as much as we used to have, but for the and we don't need to get into specifics, but just in general, with the larger, more well-established third-party payers out there, do we see where they are on the spectrum of not allowing it, a little bit of it, pushing it? Where are they?
I think we're seeing where they're allowing it, but they want you to use their provider. So, they're putting together their own provider group, who are then able to do more of a cost control approach,
Right.
potentially. So I know personally, my family's insurance, we can use telehealth if we use the Anthem provided provider, but if we want to use our own provider, then it's not an option. And I think that's an area where DC is focusing on that, because that does limit patient choice in the modality of telehealth.
Okay, let me clarify that, Cody. When you say see an Anthem provider, so if your local provider, Dr. Smith, in your community, that's your Anthem provider, that's not the same, as I understand it, as who I would get if I called Anthem's telehealth. I would get...
You'd get someone whose paycheck would come from Anthem directly, instead of someone who, if it's IU Health, if it's St. Vincent, Franciscan, whatever health system, an independent doc who has their own shingle out, that's not been an option, at least across the state of Indiana. That's the trend we're seeing. At least I'm seeing. I don't want to speak for everyone.
Okay, excellent, good. Okay, it is about 1:45, so we've taken up about 45 minutes of this session so far from panel responses to questions. We've had a few questions from the audience, but I do want to open it up now and give others on the call the ability to submit questions. We've got 3 experts here in the field of fiber and telehealth and grants that involve telehealth. So ask your questions. Let us know what your thoughts are. Anybody want to share the extent to which they're using telehealth and what kind of successes or challenges they've discovered? All right, we've got a quiet group. Is someone trying to, I'm hearing something. I don't know if it's someone asking a question or if it's background noise.
There is a question in the chat. What is the general time frame in implementing a program?
Okay, great. Thank you for sharing it, Cody. That's probably a Becky or a Cory question, but again, the question is, what is the general time frame for implementing a program? So let's take that from the standpoint of the decision has been made forward. or to move forward with telehealth? What does that time usually look like?
It's going to vary program to program, depending on what type of specialty you want to use or implement, what type of equipment you need to get. Do you have to go through the process? You know, has someone come to you who is a IT person and said, hey, we want to start telehealth? And you have to start from ground zero and do all the research and find the right vendor and find the provider. And there's so many variables. You know, I could say 6 months, but I'm sure some programs take more than that. And I'm sure some programs are up in a month.
And from the network side, typically, if you're wanting to install a fiber connection to support telehealth, usually it takes about 90 to 120 days. However, if you want to apply for the Healthcare Connect funds to help support payments towards that fiber connection, the 65% subsidy, then that process is a long one, and that's one that IRHA does a great job guiding you through. But that's where you'd want to plan for, you know, somewhere in the case of 9 to 12 months before the funding was available.
I would just clarify, this is Allie again, regarding the Healthcare Connect Fund. The process isn't technically that long of a process. We just only have a very small window during the year within which we can apply for the funding. So it's not a terribly time-consuming process. We just have to hurry up and wait in a lot of cases.
Yes, I would 80 to 90% of it is the waiting, right, Allie?
To what extent, I'm going to ask all of our panelists this, because you all probably have some information on this, but to what extent are we seeing some of the larger retailers jump into this? I've heard that Walmart does this, or they have an employee program where they can call Walmart providers using telehealth. We've seen a lot of activity on the CVS and the Walgreens front. To what has this come up, and how much of a challenge do you see this being?
So I just pulled out my phone real quick and did a quick doctor on demand search in the App Store of people that offer services and found 400 apps right off the demand. So I think there's a lot of, as technology, and especially I'll claim it as a millennial and my generation being a lot more transient and mobile. I mean, there's a lot bigger trend to that instead of having more of a rooted relationship with the provider. So I think other companies and for-profits are starting to recognize that business advantage potential.
Are others on the call seeing in their local communities, or are they hearing about that, other organizations, you know, Walmarts, if they have that in their area, or CVS's using telehealth? Okay, let's move on. I have another question. Is there any data regarding ER visit reduction in areas where telehealth is being used?
I would have to comb the literature. I haven't specifically looked for that, but that is one of the things that we're trying to track with our school-based program, is to see whether or not getting the kids care during the school day reduces ER visits.
Okay, and that's something that I will get back to the person asking that. I'm going to check with ACEP. They're actually having the Indiana ACEP, which is American College of Emergency Physicians, are actually having their annual conference this week. So I've got a couple of colleagues that are going to that. I'm going to have them ask and see if there's any data available for that, and then I'll share that back with everyone. All right, other questions from anyone? Okay, if not, I do have one final ask of everyone. If you would please let us know from which organization you're with. We do track this. So if you would take just a moment, each of you, to go down to the chat button on the bottom of your screen, almost in the center, down at the bottom is the chat button. Please use that to just give us your name and what organization you are with. Those are things that we track for our meetings that we have. And then ask them to, if you would, take the survey as well. I think Allie is sending that out to everyone. There it is. She did it as we speak. So if all of you would take that survey, it's important to us to know what we can do to make these better, to make them better for you as we continue to do these types of reviews and panel discussions as we talk about specific topics. Are there other questions before we go? All right, well, I thank everyone for your time today. It's been a very informative 50 minutes. I appreciate everybody taking time to join us. I want to thank our panelists, Cory from IFN. I want to thank Becky Sanders. And I certainly want to thank Allie Orwig for doing double duty. She's not only the Zoom host for this meeting, but she's also part of our discussion group because of her role with fiber. So thanks to all of you, and thanks for your time today. We're looking forward to checking with everyone on future events from IRHA.
Thank you, Phil, for my